Thank you very much for inviting me. Thanks for the introduction. So I'm going to dive straight in. So direct-to-consumer gut and nutrition testing is fast-moving as many other direct-to-consumer tests. So when we typically talk about that, we typically talk about three broad categories: gut microbiota, stool tests, where you get to test your microbiota diversity, and you get a report about specific groups of bacteria or bacteria. When we talk specifically about nutrition tests, we might be talking about metabolic and biomarker tests such as point of care testing or CGMs. And there's also food intolerance tests through blood here and so on. Now, all of these often are branded within the broad umbrella of personalized nutrition, but are not equivalent in terms of their analytical validity, their clinical validity, their potential for harm, and their cost. We've already heard why they're so popular. My good friend Google AI tells me that they're valued at $1 billion globally, and we feel already about the fact that people want personalization. They feel frustrated with symptoms. They might want quick and easy answers. And the reality is that there may be benefits, because for some people, the immediacy of the results and the act of testing might increase motivation for behavior change and actually lead to changes in behavior. So we'll begin with the food intolerance testing, which is probably the clearest cut, because there's no evidence that any test can do that. The simple thing that you have to do is remove the food and reintroduce the food and see whether your symptoms change. So that's that. But on the gut side of things, the measure of the gut microbiome is quite a new and exciting field, and I will talk to you a little bit about some of the studies that we have done, because the gut microbiome is clearly linked to lots of health outcomes, but establishing causality is really hard to determine here. And we don't actually have an agreed definition of what a healthy microbiome means or what gut dysbiosis means. And a lot of these tests also talk a lot about gut health. But what do we really mean about gut health? When I was initially putting my slides together, I had left it to that, but I searched a little bit online, and actually there was this paper from February that there was a consensus definition trying to talk about that, talking about a state of normal GI function without disease, without active disease, and without symptoms. So it talks not only about what happens in the gut, but also about the patient experience. Now, one major issue with the gut tests is analytical performance. And this is a study done by the National Institute of Standards and Technology in the US. And what they found was that there was major discrepancies both within and across different service providers, to the extent that the variability was equivalent to biological variability. So the authors argued that the observed differences that they found were due to measurement variability and lack of sufficient quality control. And they went one step further to say that analytical performance is actually a prerequisite for making sound clinical recommendations. So then the next question becomes, does acting on the result improve outcomes more than good standard care? This is one of my systematic reviews back from 2022, looking at weight loss interventions and how that changes gut microbiota diversity. It's not directly on direct consumer testing, but it illustrates a wider point about mechanism and clinical relevance. So in our systematic review, we looked at food-based dietary weight loss interventions, and we found no clear evidence that this changes the alpha diversity or the beta diversity of the gut microbiome. There was some evidence of dose response with the bariatric surgery studies showing a big effect and a potential effect on formula-based diets, because they do produce a larger amount of weight loss. Now, this matters because the gut microbiota is quite a trendy and emerging field, but we do need to have empirical evidence to test whether there is actually a mechanism there. So we've tried to put this to test ourselves, and using a low-energy total diet replacement program where we asked people with obesity, and in this case advanced fatty liver disease, to replace all of their foods with soups and shakes for 12 weeks, which we provided. I know it doesn't sound easy, and I know, but you will be surprised by how many people have actually, who started it, actually stuck to it pretty closely. So what we found from a clinical point of view was that there was a big change in diet and a big change in their body weight. Participants lost on average 15% of their body weight at 3 months. They maintained that at 6 months. And there were clinical effects on their liver disease as well. So, for example, their liver fat reduced from approximately 20% to about 3% at 3 months, maintained. So, big changes, very striking. And this is the sort of intervention where, if there was a large and durable microbiome effect related to the diet and related to the liver, we should be able to observe. And we collected some stool samples there. So what we've tried to ask with an additional mechanistic project that we got funding from GUTS UK was to see whether the gut microbiota is part of the mechanism through which weight loss exerts its effect on the liver. We measure this in all sorts of ways, from alpha diversity, beta diversity, the relative abundance of different phyla, genera, species of bacteria, but we found no evidence of a difference in most of these, certainly the alpha, the beta diversity, and the major phyla and genera. So I was very surprised by these results, to be honest with you, because when you had such a big change in diet, you would expect big changes in the microbiome, and we didn't see any. Of course, we had a small sample. That might be one of the reasons, but we actually saw very big, large clinical improvements without detectable changes in the gut microbiome. So what we concluded was there was no evidence to support the therapeutic value of changing the microbiome to improve advanced liver disease in this context. Now, moving from the microbiome mechanisms to personalized diet interventions more broadly, there have been trials who've been trying to test whether personalized nutrition based on various biomarkers, including the gut, genes, urine, and so on, might have better outcomes. And this is really a promising and exciting field. One example is one randomized controlled trial from Denmark, where they had a personalized 10-week plan based on urine, plasma, serum biomarkers, and SNPs. So they tailored the meals that they provided to people based on all the testing that they did, and they compared this against providing meals that are just standard. The important thing here is that in both groups, they match the intensity of the support that they provided to both groups. And this is important because the amount of support people get in typical general weight management programs is the strongest indicator of success. So this can let us know if the personalization can add something above and beyond that. And what they found was there was no evidence of changes in body fat, body weight, or other outcomes. You can see here the differences in body weight between the two groups. There are also new algorithmic approaches, including personalized dietary advice based on foods, CGMs, triglycerides, muffins, microbiome data, and so on. And what you see here is that the algorithm produces approximately 2 kilos of weight loss for those who started the program, and 2.5 kilos weight loss for those who actually stuck and completed the program. Now, this is an entirely indirect comparison and not a head-to-head with the standard that is available for people with obesity and diabetes or hypertension in the NHS Digital Weight Management Program. But you can actually see that this produces comparable, if not slightly better, effects for those who complete it. And so it is very hard to argue that there is at least a signal of that personalization might be better. The way that this might have worked better would be that the personalized algorithm would be way cheaper than the NHS digital weight management program, but we estimate that it's approximately triple the price compared to the level 3 NHS digital program of 100 minutes of coaching. Now, some biomarkers are clinically useful, HbA1c, for example, but on the direct consumer point of care testing, there was a recent study found that only 26% of these devices meet the international standards on independent evaluation. But even with this room of error, it might be a little bit helpful and useful to assess the response of on diet and weight loss interventions. Another useful example is vitamin D, because vitamin D deficiency is quite common in the UK, especially in the winter. And NHS advice is that everyone should consider a vitamin D supplement, especially during autumn and winter months. And one of the reasons that this advice came was that prophylactic supplementation is much more cost-effective to the system than large-scale testing. But the challenge that we have is that promotion, uptake, and adherence to supplements is poor. So from a consumer perspective, I think that here we have a case where testing might be seen as better value for money if it helps somebody decide whether they need to spend money on supplements and keep on sticking to taking them on. With the CGMs, John mentioned that already in his talk earlier in the morning, they are definitely very they're arguably and evidence that they're very clinically useful for people with diabetes, but the evidence on people without diabetes is much weaker because they might lead to unnecessary and potentially harmful diet restrictions, anxiety, and narrow focus on glucose spikes that are part of normal physiology and no good evidence that they are linked to outcomes. Now, if we imagine a future where actually personalized nutrition through all of this testing is effective, the next argument that we need to achieve is cost effectiveness, because this is when this can actually be economically sustainable. And here you can see some data that my colleague Nicola Guest in the department put together, where you can see pairs of costs and effects for a program to be considered cost effective. So here, something needs to be delivered at less than £100 per person and lead to long term to a 1 kilo weight loss. Some further considerations that I think we've already been covered, so I'm not going to spend too much time on them. Inequalities in access, so many of these tests are expensive. How much this is going to lead to increased pressures in the NHS. There's a big conflict of interest. We've seen it in the previous talk from Tim as well, about recommendations or sales of other supplements or subscription programs with minimal evidence of efficacy. And also another point about aggressive marketing, where it is quite commonplace for some organizations to use scientific association to support commercial credibility. So in summary, personalized nutrition is an emerging and evolving field. Some tests are meaningful in specific contexts, for example, CGM for diabetes, potentially vitamin D. But we've also seen that more information is not necessarily better, where many of the testing that was done to deliver personalized nutrition intervention hasn't led to more weight loss than standard good solid advice. So many of these current tests are probably better used as consumer wellness, and I do see that we have to use this field as an opportunity to make this personalization much more evidence-based, clinically relevant, scalable, and cost-effective. Thank you. Look forward to it.